Hello, and I'd like to thank the organizers of the meeting for inviting me to present this particular lecture. My name is Dr. Gregory Sawicki. I am a pediatric pulmonologist at Boston Children's Hospital and at Harvard Medical School. And I will be talking to you today about a topic that is quite important in terms of the global care of people with cystic fibrosis. And that is the transition from pediatric to adult-focused care. I'll be speaking specifically about challenges and strategies for successful transition. As you have heard throughout this conference, there have been great advances in the care of people with cystic fibrosis over the last several decades. And in fact, the story of cystic fibrosis is one of great success. In this slide, as you can see, in the 1950s, the vast majority of children with cystic fibrosis were quite ill, presenting with malnutrition and chronic respiratory disease. And as we all know, morbidity and mortality was quite high in childhood. It was little over 30 years ago that the gene for cystic fibrosis was discovered in 1989. And this opened the floodgates for further research into understanding the basic underpinnings of the disease, and has led to some of the newer therapies that you have heard about in other forums during this meeting. As a result, survival in cystic fibrosis has continued to increase throughout the globe. And as you can see on the picture on the right, the body image of an individual with cystic fibrosis is now quite different. This is an image of a young woman with CF as part of a collection of photographs of young women with CF thriving and living well into adulthood. What we have witnessed over the past several decades, therefore, is a real changing epidemiology in the types of patients that are living with cystic fibrosis. On this slide are data from both the United States and Europe. As you can see in the panel on the left, in the United States, the number of adults living with cystic fibrosis now exceeds the number of children living with cystic fibrosis. And that inflection occurred sometime around 2012. As opposed to the mid-1980s, where only a third of patients with CF in the US survive into adulthood, now well over half of our patients are living into adulthood. The graph on the right shows similar data from Europe, from the recent ECFS registry report. And as you can see, on average now, about 50% of CF patients in Europe are now over the age of 18, with some variation from country to country. That said, as better therapies occur and outcomes continue to improve, we fully expect that in the next couple of years, the number of adults living with cystic fibrosis will only continue to increase. Adults with CF are also pursuing higher education, are members of society working, starting families, and having full adult lives. This is data from the United States CF patient registry showing that over 2/3 to almost 3/4 of all adults with CF in the United States have at least graduated high school, and many have graduated college or university. Many are now working full-time or are students, and thus are very productive members of society. Thus, as healthcare outcomes have improved, it is important for us as healthcare clinicians to really provide systems of care that allow for adults with CF to succeed both from a physical health perspective as well as from an overall psychosocial health perspective. We also know that adolescence remains a high-risk period for those living with cystic fibrosis. Despite the improvement in outcomes, what we have seen over time in the United States, as well as in other parts of the country, of the world, is that lung function decline is still most rapid during the period of adolescence. What this graphic shows is that if you look at birth cohorts of patients with CF that were born in the mid-1980s compared to those born in the 2000s, the kids at the age of 6, 7, and 8 are starting out with improved lung function, and this is likely a factor related to better newborn screening, earlier diagnosis, and earlier attention to treatments and complications. However, the slope of decline of lung function during the ages of adolescence continues to be very similar, albeit at a higher trajectory. Therefore, adults are reaching adulthood with better lung function, However, there is still a rate of decline of lung function during adolescence that needs to be addressed at a population level. And why is this? There are many challenges for adolescents and young adults who are living with cystic fibrosis. Particularly for adolescents, they often may have a lack of independence. They grew up with cystic fibrosis as a genetic condition that they were born with, and they often view CF as a problem that their parents are taking care of. Adolescents and young adults may have competing priorities and feel that CF is not the biggest priority and their health is not the biggest priority. They focus more on their schoolwork, their work, their family, their friends, and they sometimes may ignore their health care. Adolescents and young adults may often minimize symptoms and not realize when they need to seek medical attention. And adolescence developmentally is normally a period for the emergence of risk-taking behaviors, including, but not limited to, cigarette smoking, which can be detrimental to someone's respiratory health. It is also clear that adolescents and young adults have many challenges with adherence to daily therapies. They may say things like, why should I do all my treatments every day, especially if I don't feel any different on my day-to-day regimen? Or they may say, I don't have time to fit in all of my treatments, and therefore may skip treatments, much to the detriment of their longer-term health. And as you have heard in other forums in this conference, there are mental health challenges that can arise with living with cystic fibrosis, particularly anger at their condition or anger at their caregivers or parents. And depression and anxiety are also quite common, leading to significant challenges in providing care to adolescents and young adults with CF. Data from the United States does support this. Here is data looking at adherence rates in CF. And what you can see here is a metric called the medication possession ratio. This is a data point that is obtained from looking at pharmacy refill rates. So for instance, if a patient is prescribed a medication and they are prescribed the medication to take daily, you would expect that they refill their prescription every month. And so a pharmacy can calculate how many times a patient has actually picked up their medication. The red line reflects 50% medication possession ratio, or MPR. And that means that 50% of the medications were picked up or received by the patient or individual. What you can see here, and this is now data that was presented by Dr. Alexandra Quittner over 5 years ago, is that in the ages of 18 to 25 and 26 to 35, when looking at pharmacy records, the average medication possession ratio in a population of people with cystic fibrosis was below 50%. So we know that people with cystic fibrosis are not receiving all of the medications that we as clinicians prescribe by virtue of the fact that they simply are not receiving them on a regular basis. And that this is a worse problem for adolescents and young adults who are going through this transition period. So what is healthcare transition? As I've said, it's a critical process that needs to be addressed by the CF clinical community as more and more adults are surviving with cystic fibrosis. In the United States, the American Academy of Pediatrics has defined healthcare transition as a purposeful, planned process that supports adolescents and young adults with chronic health conditions and disabilities to move from child-centered to adult-oriented healthcare practices, providers, and facilities. The goals of the healthcare transition process are as follows. 1, to promote autonomy and skills for self-management. In other words, somehow allowing and teaching an adolescent and a young adult to take care of their health on their own and not rely on their parents or other caregivers. A second goal is to allow an individual to assume adult roles and responsibilities, whether that be setting up their medications, picking up their prescriptions, making their appointments, going to appointments alone and speaking with their physicians alone, as well as learning how to take care of themselves and balance their priorities, including school and/or work. A third goal is addressing health knowledge. Because children are often diagnosed with cystic fibrosis when they are younger, a lot of the education that clinicians provide is to the family, the parents, the grandparents, or other caregivers. But sometimes some of this knowledge does not get transmitted by the family to the adolescent or young adult. And so a robust transition program also needs to ensure that the adolescent and the young adult is aware and knowledgeable about their condition. Just like everything we do in pediatric care, we think about developmental perspectives, and adolescence and young adulthood is yet another developmental time frame for those living with cystic fibrosis. And when the health system operates in such a way that transfer of care is allowable or available, the goal of transition is to prepare a youth and a family to transfer their care from a pediatric-oriented to an adult-oriented service in a way that is uninterrupted and does not lead to a lack of care during a particularly precarious time from a developmental perspective. It is important to realize, however, that transition does not always result in transfer of care. There may be places around the world where adult clinicians or adult CF programs are not available or do not have sufficient staffing. That does not mean, however, that an adolescent or a young adult should be treated the same as a child or someone younger with cystic fibrosis. Even if the same clinician is providing care for a 12-year-old, an 18-year-old, and a 25-year-old, the way that we approach the care of each of these individuals needs to be different. A 25-year-old should be treated like an adult, an 18-year-old should be treated like an emerging adult. And so even if there is not transfer of care, the transition process, the assumption of adult roles, the encouragement of independence for the youth needs to occur. And why not just stay with pediatricians or pediatric specialists? Many of the CF clinicians around the world were trained in pediatrics or pediatric pulmonology. However, they lack expertise in adult medical care. Pediatricians don't always have developmentally appropriate care for adults and may not be aware of the preventive care needs of adults. And again, with newer medications leading to better outcomes in those with cystic fibrosis, the attention to adult primary care issues, preventive care issues, as well as screening for other adult-focused CF complications is best served by those who have specific expertise in the care of adults. And so our goal should be this: a process that occurs over a longer period of time that starts during pediatric care and ends with adult care. During pediatric care, the role of the clinician should be to prepare a family and an individual for transition and transfer. There should be a therapeutic discharge from the pediatric programs, an active transfer process to the adult clinicians, a handoff that is planned, that includes sharing of information and data. There should be an intake process in which adult clinicians then take on new patients and new families and help establish young adults in an adult care system. This is easier said than done. And for many decades, the healthcare systems in the US, in Europe, and other parts of the world have struggled with optimizing transitional care for those with chronic health conditions, including cystic fibrosis. So what are the problems? The barriers can be coming from the youth, the parents, and the family, but they also can be coming from the pediatric clinicians, pushback from the adult clinicians, or from the way the health system is organized regionally as well. What are some of these youth or family barriers? Well, I've already mentioned that knowledge and skills around conditions and cystic fibrosis can be a problem. Health literacy is often a challenge, particularly in certain subpopulations. And as I said, a lot of adolescents and young adults rely on their parents in terms of self-management and may not have the ability or skills to manage a condition like cystic fibrosis and the treatment demands of cystic fibrosis on their own. A family or an individual may be resistant to transferring to an adult care team. They are very familiar with their pediatric clinicians. These are the doctors and nurses and others that have cared for them since they were diagnosed as a young child. They may be afraid of a new team or a new facility. The family feels like they need to maintain control, and they may also perceive that an adolescent or a young adult who has been relying on them for many years cannot handle independence or managing the condition on their own. And thus, in addition to knowledge and skills, a family may be resistant to sending a young adult to an adult specialist on their own. Finally, in certain parts of the world, insurance coverage and around primary and specialty care may limit access. And in other parts of the world, there may just not be the training and availability of adult-oriented specialists to provide care for the rising rate of adults living with cystic fibrosis. And that brings us to the health system barriers, which, as I've said, are often quite common. Before the last several decades, it was not unusual for adult pulmonologists in the United States to not be trained in cystic fibrosis, as they did not see very many patients with cystic fibrosis, as many of them were not surviving into adulthood. This has had to change, and it has had to change quite rapidly over the last several decades. But it's not only the training of adult specialists. Pediatric specialists also need to be trained in transition planning and thinking about how to treat adolescents differently than children, how to teach adolescents to take better care of themselves, to learn about cystic fibrosis, to improve their adherence skills, to improve their self-management skills. And ultimately, in a busy clinical arena, there may be lack of time and training to provide specific counseling when day-to-day healthcare issues are more pressing. And again, in certain parts of the world, particularly in the United States, we've seen some challenges with health insurance coverage during the period of transition. This has been improved recently with some policy decisions here in the US, and certainly may not be as applicable to other systems around the world. So those are the barriers that I wanted to point out at both a youth, family, and health system level. But we've also learned a lot about what we can do to improve transition to adult care services. We need to develop partnerships between pediatric and adult programs, partnerships between pediatric CF specialists and adult CF specialists. We need to think about how to improve skills for chronic disease self-management. We need to think about programs to improve adherence to therapy. We need to think about how do we assess readiness? How do we look at an individual patient with cystic fibrosis or their family and say, what are the skills that they need to learn in order to become successful adults? We also need to define what are the right outcomes of successful transition. What are the physiologic outcomes? What are the functional outcomes? How are we measuring quality of life? How are we measuring adult milestones, such as vocation or education or employment? And ultimately, we need to think about how do we coordinate care across two different programs, potentially two different institutions, and in some places, two different cities or locations of care, depending on where pediatric and adult programs are residing. So how can we proactively address these challenges? I recommend that you initiate early and progressive education and patient self-care, starting even during earlier childhood. Although a younger child may not be able to set up a nebulizer on their own, they know that they're taking pancreatic enzymes regularly, and they should be able to tell you, even at an early age, why they are doing these treatments. You need to involve everyone in transition, not just the adolescent, not just the caregivers, not just the parents. This is everyone's business. You want to look for opportunities to promote self-management, even for younger kids. And you also want to promote comprehensive referral and communication with adult services. And if you're an adult clinician, you want to think about how you're best communicating with young adults as well. Learn about all aspects of their lives. Make sure that that you understand that they're afraid of meeting new staff and new clinicians. And so perhaps do the transition and transfer of care slowly over a short period of time. And don't forget that parents are still a part, and families are still a part of the care of even young adults with cystic fibrosis. Just because you're an adult-centered clinician doesn't mean that you don't incorporate care of the entire family. We have developed many different resources in the United States related to transition of care in cystic fibrosis, and I'm going to point out one in specific. It's called CF RISE. The RISE stands for Responsibility, Independence, Self-Management, and Education. And this is a CF-specific resource that has been approved and vetted by the US CF Foundation as well, and creates both a toolkit of both written, printed, and online checklists, quizzes, and skills information sheets. Knowledge assessments can be administered by clinicians that focus on many different important areas of cystic fibrosis care, including lung health, nutritional health, diabetes, sexual health, college, education, employment, as well as skills such as working with your care team, living with CF, financial planning, and education planning. Some of these assessments may be specific to issues related to the US healthcare system, but many of them will be applicable to systems around the world. The UKCF Trust has also put out a guide for families and caregivers around transition to adult care that can be downloaded from the website that is indicated here. And again, any of these references and resources can be obtained by contacting myself or others, and we will certainly be willing to send you in the direction of getting some of these resources for your own clinics. These resources currently are only in English and have not been translated to other languages, but certainly there would be efforts that could help with such an effort as well. So where are we? We've done a quick tour of transition into adult care and cystic fibrosis. I hope I've explained to you that it's important that all of us who care for those with cystic fibrosis, whether we be pediatricians or adult specialists, pay attention to the importance of this developmental process. We know that more adolescents with CF are now reaching adulthood, so we need evidence-based approaches to improving disease self-management. Despite everything I say, when we look at data in the US, there are still poor levels of transition preparation and planning, and more work needs to be done. And therefore, many of us at our own care centers are continuing to try to develop better guidelines and plans for transition. There are many barriers, as I've noted, but we need to also incorporate the perspectives of youth, family, and health system leaders in order to overcome these barriers and develop effective transition programs. But it's important for us to not just say it's important and assess the barriers. We know what the problems are. We know that it's important, and we can all agree that identifying ways to develop high quality transition programs is essential. We need to improve access to care for all of those who need adult-based CF care. We need to improve how we coordinate our care, and we need to work together to maximize a patient's journey to adulthood. And ultimately, we need to involve research into the impact of such programs and preparations to continue looking at outcomes in adulthood, because it's not just the medications that will help people with CF live longer and healthier lives. It's how we provide the care to these patients and families throughout their entire lifespan. I'm happy to participate in any questions in the future. If you would like to send me any questions via email, I am sorry that I'm unable to join you as part of the live Q&A for this meeting, but I hope that you have found some of this information useful and helpful. And again, I'd like to thank the organizers for allowing me to present today. Thank you very much. Okay, thank you for the additional questions that have come through. The first question is as follows. Children mature differently in different cultures. Do you think a set age is fair to all children to initiate the transition process? That is actually a very important question, and it is absolutely true that children do mature differently, not just based on culture, but based on how their family functions, about their own individual circumstances, and their own innate abilities. And so this question around whether transition and transfer of care should occur at a set age versus at a developmentally appropriate time is something that arises a lot, even in our practices here in the United States. In general, I believe that it should not be a set age that is the marker for a time to transition or transfer care. Rather, our teams should be working together, as I've mentioned, in a collaborative fashion to identify which youth and young adults may be ready for transition or transfer earlier, and maybe others that may require a little bit more time. What that means, however, is that we should still start assessing whether a child and a family are ready for transition at an earlier age during adolescence, but understand that that transfer of care to the adult team may be different for every different individual. For instance, some children may be finishing secondary school and be able to manage their medications and be able to manage their health and understand their condition and may be very ready at the age of 18 or even earlier at age 16. Whereas others who may have some intellectual disabilities or may have some more challenges with their own health or their families may require a little bit longer. Additionally, children who may be sicker may actually be more aware of their own health and may be ready to transfer sooner than those who may be less sick and have less attention paid to them during their adolescence. So again, I think what I would advocate for is a not one-size-fits-all approach based on age, but an approach in which assessments are done periodically in terms of how ready an individual or a family is for transition, and then to think through it on an individual basis. The second question also is an important question. It states, separation anxiety from the pediatric treating team that has been looking after a child for many years is common. How do we best prepare the child and family? That again is an excellent question when it comes to how a system works to help prepare a family and an adolescent for eventual transfer to adult care services. And I think this again, there are multiple ways to approach this, but the first is to be consistent in starting assessments around self-management practices early on in adolescence. You know, the recommendations that we say is around age 12 or 13, it is at least time to start focusing education for the youth and not so much for the parents. Maybe if possible, separating the parents and the children during a routine office visit so that you can speak to the adolescent by themselves to see where their concerns are, where their knowledge is, what their gaps are, what their questions are. That can be often anxiety provoking for a parent as well, but is often then enabling a child to take more ownership of their care. The other piece that's important is that close coordination between the pediatric and adult programs. If there is good coordination and communication, this kind of anxiety from parents around separation from a pediatric center may be lessened. And this is, in fact, something that we do here in our centers is sometimes we have joint visits where the adult clinicians come and meet the family during a pediatric visit, or we may alternate visits, one visit with the pediatric team and another with the adult team. So that kind of different models of care definitely do exist, or having a dedicated transition clinic with members of both teams, or tours of the adult clinic or the adult hospital that has been shown to alleviate some anxiety. So again, it's about coordination, education, and early messaging. And it's important for everyone on the pediatric team and the adult team to reach agreement as to how to best approach each individual family.